Traditionally, lung cancer and carcinoma has been classified as small cell and non-small cell. So, non-small cell is basically what it means. It's composed of large cells with abundant cytoplasm. And small cells is composed of basically small cells. There is no cytoplasm, just a nucleus, very closely compact cells. And the traditional model of lung cancer pathogenesis is also based on the same principles like the tumors arising from the central compartment are usually seen in smokers, and those carcinogens act on the bronchial mucosa leading to cell proliferation, and the cancers associated with the central airway disease are squamous carcinoma, small cell carcinoma, and those associated with the peripheral terminal respiratory unit are usually seen in non-smokers associated with driver mutations like EGFR, and histology is that of an adenocarcinoma. So now the classification has changed over the years, and there are a lot more entities which are added and a lot more mutations which have been discovered as more and more cancers have been sequenced. So this is the evolution of the classification and addition of the entities over the years. So first it was just small cell, non-small cell, then small cell they subcategorized, non-small cell also they subcategorized. And coming to the 2021 classification, this is an extensive subtype based classification, and we'll be covering some common entities and some newly described entities as well. So, coming to a basic concept. So, you can see this is the normal bronchial mucosa and underlying cartilage. So, what happens is, as you can see in this figure here. So, basically, when the bronchial mucosa gets irritated by, let's say, carcinogens in nicotine and other things, so the mucosa gets irritated, it starts proliferating, and the cells start proliferating inside the outpouching, and the cells do not yet cross the basement membrane. So, the cancer progresses from a benign to an in situ disease, and once it crosses the stroma, it's an invasive carcinoma. Similarly, tumors arising from the peripheral terminal respiratory unit, there is an intraalveolar proliferation, and once the proliferation starts filling up the alveoli, it forms an adenoma, and then there is atypia, which resembles a pre-invasive cancerous lesion. And once the tumor cells cross the basement membrane, it forms an invasive carcinoma. So we'll be covering some benign entities followed by pre-invasive lesion and the invasive cancers. So the benign papillomas and adenomas form less than 1% of the lung tumors. So these are some of the common, not common, but that are seen in practice. So this is a squamous cell papilloma of the bronchial mucosa. And like squamous cell papillomas elsewhere is also associated with HPV infection. And, you can see that it's lined by squamous epithelium and it has a very papillary look. But there is no atypia and there is no invasion. So this is a squamous cell papilloma. So similarly, there can also be glandular papillomas, which are very rare. And then there are also some other benign entities like alveolar adenoma. So you can see this image. So this is a very localized proliferation. You can see that at the periphery, there is normal alveoli, and this proliferation here, it's a very defined proliferation composed of very benign looking glands, and there is no invasion into the surrounding stroma. So this is an alveolar adenoma. So there are also some other entities like sclerosing pneumocytoma. So this has a dual cell population and associated with AKT mutations. So why are these entities important is that in small biopsy specimens, it is sometimes difficult to distinguish these between the invasive adenocarcinoma. So here it is always important that we do immunohistochemistry for myoepithelial markers because in all these entities, a basal myoepithelial lining. So basically a gland has a central tubular unit which is associated with the function of secretions. And there is a lining myoepithelial cell layer all around the glands. So if that myoepithelial cell layer is intact and if you are able to show that on immunohistochemistry and the lining cells are very benign, there is no atypia, they don't look like carcinoma cells. So in small biopsies, we can rule out an invasive tumor because like if we see sclerosing pneumocytoma, so this can be easily confused with a low-grade papillary adenocarcinoma because there are small tufts and lined by those cuboidal, banal-looking cuboidal cells. So these entities are usually seen in very early stage resections. So we don't get to see the entirely resected tumors here, but sometimes in biopsy specimens we do encounter these. So this is a bronchiolar adenoma or ciliated muconodular papillary tumor. This is a newly described entity and usually affects the peribronchiolar mucosa. So similar to the previous entities, this can also be confused with an invasive adenocarcinoma in a small biopsy. So this is very rare. I have not seen it in practice yet. But it is associated with BRAF mutations and there is an intact myoepithelial cell near it. So these were some benign entities. Now coming to pre-invasive lesions. So, first we'll discuss the epithelial tumors, followed by some neuroendocrine and mesenchymal tumors. So, pre-invasive lesions can be, they are a spectrum basically. So, starting from an atypical adenomatous hyperplasia. So, what happens is that the cells lining the normal alveoli, they become atypical and they proliferate only along the alveolar lining. So this type of proliferation is called invasion through a lipidic pattern. So it is not going into the stroma, but the cells are just lining the alveoli. So this is the lipidic pattern of involvement. So if that proliferation is less than 5 millimeters localized, that is called an atypical adenomatous hyperplasia. So this can only be diagnosed in a completely resected specimen. You cannot diagnose it in small biopsies because if we see this in small biopsies, it could be a peripheral component of an invasive adenocarcinoma. So when that atypical adenomatous hyperplasia progresses and the size increases to around 3 millimeters, so that is an adenocarcinoma in situ. And even the cells lining the alveoli, you can compare these two entities that the cells lining these alveoli, they appear larger and they are darker. So the nucleus is more hyperchromatic because there is more amount of nucleochromatin and proliferation. So if the growth is less than 3 centimeters, composed of a pure lipidic growth pattern, there is no invasion anywhere. So we will see what are the patterns of invasive adenocarcinoma later, but those patterns should not be seen. And in addition, even any focus of invasion like lymphovascular invasion in other parts of the lung or any other spread through alveolar spaces, we'll be talking about that later. Even that should not be seen And similar to the previous entity, this also cannot be diagnosed on a small biopsy. You need a completely resected tumor. So it's always recommended that we sample while grossing. If there is a specimen that is less, almost 3 centimeter, it is recommended that you sample it entirely. Because you have to rule out any small focus of invasion, because then that will become an invasive, minimally invasive adenoma. So, minimally invasive adenocarcinoma is where the size is 3 millimeters, but the invasive component is less than 5 millimeters. So if it is more than 5 millimeters, it becomes an overtly invasive adenocarcinoma. And this is also important because the T size depends on the size of the invasive component only, and that is used for T staging. And coming to invasive adenocarcinoma, it is of 2 types: mucinous and non-mucinous. So, non-mucinous invasive adenocarcinomas are the maximum commonly seen entities in practice, while mucinous are around 3 to 10%. So here you can see a gross image of an invasive adenocarcinoma. So this is a peripherally located tumor. So classically described adenocarcinoma peripherally located. There is some anthracotic pigment. And this is the cytology of the tumor. You can see that the individual cells are large. They are seen as a cluster. So these prominent dots here are the prominent nucleoli. So this is the cluster of adenocarcinoma cells. So adenocarcinoma is, you can see various complex admixture of patterns. So what are these patterns? So lipidic pattern is what we talked before. This is just along the alveoli. But if just lipidic pattern is present, we cannot call it invasive adenocarcinomas. It should be associated with any other pattern like acinar. Acinar is basically glands or tubules which are seen in the stroma. So you can see these glands which are infiltrating. This pinkish thing is the stroma, and these glands are infiltrating the stroma. And the cells lining these glands, they are showing, these are not uniform in size. They are very darkly staining. So this is an invasive tumor of showing an acinar pattern. So similarly, if multiple glands fuse, so this is a complex glandular pattern. And you can see here that there are multiple glands which are superimposing on each other. This is the cribriform pattern. This is not separately described, but it is a poorly differentiated pattern of an acinar adenocarcinoma. So similarly, there is something called as the papillary pattern of adenocarcinoma. So papillary is basically a projection with cells which are seen at the sides of the projection, and inside the stroma there are blood vessels. So this is what we call as the fibrovascular core, and the cells are lining the sides of the core. This is another pattern of adenocarcinoma. Or when the cancer progresses, there is so much proliferation that the patterns are not discernible and it forms a solid mass. So that is a solid adenocarcinoma. And there is another pattern which is called as micropapillary. So what is the difference between papillary and micropapillary is that micropapillary do not have any fibrovascular core. So these are seen as tumor cell cluster with some spaces around them. So solid and micropapillary have been described as poor prognostic patterns. And there are also some studies which show that there is better chemotherapy response if these patterns are seen. So the new WHO also recommends us to grade the adenocarcinomas based on the presence of these patterns. So grading is only possible in a resected specimen. So because we can see the entire tumor, we can just judge how much each pattern is represented as a percentage. So you must have seen reports like 50% SNR pattern or 20% solid pattern. So it is recommended to quantify individual patterns because the grading is based on the percentage. So if it's a pure lipidic tumor with less than 20% high grade pattern, it is well differentiated. If there is axillary or acinar or papillary predominant with less than 20% of the high grade patterns, it is moderately differentiated. And any poorly differentiated pattern, more than 20%, it is poorly differentiated. So coming to what immunohistochemistry tests we use to diagnose an adenocarcinoma. So IHC is basically detection of antigens on your tissues. So you can design any synthetic antibody against any tissue which is seen on the slide. So the basic chemistry of IHC is that an antibody binds to the antigen on the tissues, and we use enzymatic chemistry to assign a color to that antibody. So here, this is a core biopsy, and you can see some infiltrating glands and clusters in the stoma. So we have added TTF1 and NSCLC, which are markers of specific for lung differentiation. So TTF1 is a transcription factor. So it's specific for lung and thyroid. And since it's a nuclear transcription factor, the localization of that antigen is in the nucleus. So here you can see brown staining as dots. So these dots represent the nuclei. So this tumor is TTF1 positive. So it's an adenocarcinoma. So TTF1 is also obviously seen in normal lung also. And so the second lung specific marker is napsine. So it's an aspartic protease. So this is an enzyme. So this is localized to the cytoplasm. So it is usually seen as granular staining inside the cytoplasm of the cells. So I don't know if you can make that in the picture, but this is dot brown staining in all the cells. So that is napsine positivity. So usually we don't use TTF and napsine if there is overt glandular differentiation that we can see on the slide. So when are these IHCs important? So one is if there is a non-small cell carcinoma in the biopsy in a complete solid pattern. So we cannot assign whether that is squamous or adeno. So in such cases, we use a basic panel of TTF1 and P40. So P40 is a marker of squamous differentiation. It is a truncated P63, which is part of the P53 family. So that is also a nuclear transcription factor. So here we can see that in this core biopsy, the tumor is showing some solid clusters. This is the stoma, this is the anthracotic pigment, and this tumor is showing solid clusters. And these are very pink looking cells. So it's very confusing if this is a squamous carcinoma or an adenocarcinoma. In such cases, we do a basic panel of TTF1 P40. So here you can see that TTF1 is showing that dot brown staining in the nucleus. So this is positive, this is an adenocarcinoma in solid pattern. So in small biopsies, if such a scenario is there, so we usually report it as non-small cell carcinoma, favor adenocarcinoma. So, and if neither of the markers are positive and just CK7, that is marker of the upper aerodigestive tract, if that is positive, then we usually assign it as non-small cell carcinoma NOS because a definite differentiation cannot be appreciated. So, coming to some biomarker IHCs which are done in adenocarcinoma. So this is a lung biopsy from non-small cell carcinoma. And so this is the ALK IHC. You can see that it is showing dense brown staining. There is some, you can appreciate a membranous kind of staining, and it is very dark. So if it is uniform dark throughout, we call ALK-IHC positive. So it's a reliable and validated US FDA approved assay. So Ventana D53 clone is a standard companion diagnostic assay. And what we detect is after the ALK fusion, a chimeric ALK protein is produced, which can be detected by IHC. So this is how we run the ALK-IHC test. There is always a control TMA, which has, you can see there are some negative staining tissues and this core of tissue, which is positive staining. So in every batch, there is always a control IHC which are run because we have to be sure that the test has worked properly. So, and even this is the case that we are talking about, which is showing ALK positivity. Along with that, we also run a slide of the same case without the antibody, so that any staining from the reagents is picked up. So we try to cut all loose ends, that there should be no false positive staining, because this is supposed to be a very sensitive test, and use of proper controls is essential. So how to interpret that as positive strong diffuse cytoplasmic granular staining, that is positive, 100% accordance with FISH results. And if it's a completely negative staining, that is labeled as absent. But if it is weak to moderate, we have to confirm it with FISH. So usually the histologies associated with these are solid micropapillary, and specifically described in literature is a signature cell adenocarcinoma. So this is just added an image of an ALK-positive tumor. So there are some cells which are ring-like containing leucine. So these are the signature cells. If this pattern is present, you have to suspect that it could be an ALK-positive tumor. So this is another case of lung adenocarcinoma. So this is the Ross IHC. So similar to ALK, Ross IHC staining is also present in the cytoplasm. But unlike ALK, the staining for Ross is not uniform. So it is recommended that we give a score. So this score is called the H score. So how do we calculate the H score? Is we have to calculate the percentage of cells which are strong staining, moderately staining, and weak staining. And this is a formula that H score is 1 into percentage of cells which are weak staining, 2 into moderate staining, plus 3 into strong staining. And usually scores above 80 to 100 correlate with a positive FISH test. So we use the D4D6 cell signaling antibody clone. So there are other clones also in the market, but this is the most widely used. And this case, this went for FISH because any Ross positivity on IHC, you have to go for FISH. So we did a FISH in this case, and it is showing loss of red signals. So and there are occasional splits also, but loss of these red signals corresponds to Ross gene rearrangements. Another biomarker that we test by IHC is PDL1. So PDL1 is present on the tumor cells. So this is a mechanism to evade the host immunity by the tumor cells. So and obviously there is use in the to check which tumors are more responsive to immunotherapy. So this is a lung biopsy, weakly TTF1 positive lung adenocarcinoma, and this is the PDL1 22C3 clone. So here also you can see brown staining in all these cells, diffuse strong. So the tumor proportion score given here was 95% because almost all the cells are staining. Similar to ALK, we also run a negative reagent control slide along with PDL1 and control similar control TMA showing. We don't run a TMA. Or the tonsil is a normal PDL1 control which is run in every batch. So how do we calculate TPS and CPS? TPS is uh, total number of PDL1 positive tumor cells divided by number of total number of tumor cells into 100. So that is expressed as a percentage positive PDL1 cells. And CPS, that is combined proportion score. So that is number of PDL1 positive tumor cells plus immune cells. That is all the cells which are showing PDL1 positivity divided by total number of tumor cells into 100. So this is a summary of the PDL1 assay approved for non-small cell cancer. I will not go in detail. You must know better. Basic cutoffs are defined for PDL1 22C3, which is more than 50% PDL1 positivity and more than 1% using first line and second line settings. So coming to some other subtypes, so there other subtype is a mucinous adenocarcinoma of the lung, relatively rare. And these are cells, columnar cells showing intra and extracytoplasmic mucin. So these are KRAS driven. The important thing is these are negative for the specific markers. So these are positive for CK7. These could express focal markers of intestinal differentiation. So we also have to rule out any region in the GI tract. So similarly, another entity, enteric type of adenocarcinoma. So these cells show colorectal differentiation in more than 50% of the tumor. Similar to the mucinous, these are KRAS driven and negative for lung-specific markers. These actually could show more diffuse staining for CK20 CDX2. And it is important to exclude metastasis from a colorectal adenocarcinoma. This is another type of an adenocarcinoma resembling the fetal adenocarcinoma, resembling the primitive lung. So the important thing is it's a low-grade adenocarcinoma and it shows CTNNB1 mutations. And I would like to mention another entity that is pulmonary blastoma. This is actually described under sarcomatoid carcinomas, but since it has a component of fetal adenocarcinoma, along with a mesenchymal component, I have just described it here, that it is a biphasic aggressive tumor. Coming to squamous carcinomas. So, squamous carcinomas also progress from metaplasia to dysplasia, severe dysplasia, and invasive squamous carcinomas after accumulating various mutations. So, the criteria for squamous carcinoma is that you have to see keratinization, that is this pinkish keratin inside the cells, intercellular bridging, or any IHC demonstration of a specific squamous marker. So squamous carcinomas are keratinizing, non-keratinizing, and basaloid. And this is also the cytology for squamous carcinomas. We can see elongated cells with hyperchromatic nuclei. This is a PAP stain, so keratin stains orange. So you can see some orange cells with dark staining nuclei. So these are pointed towards squamous carcinoma in cytology. So squamous carcinomas can also be non-keratinizing, and there is a basaloid type, which is composed of small compact cells. So to diagnose these, IHC is important. So we generally use P40, which is a nuclear marker, and other markers are P63, CK56, and desmocollin, but these are less specific. P40 is more dependable. So coming to adenosquamous carcinoma. So this shows both components of adenoscarcinoma and squamous carcinoma. and it is recommended that each component should be more than 10%. So even this entity is diagnosed only on a resected tumor, not in the biopsies. In biopsies, like as you can see in this code, a part of the tumor is staining for TTF1, part is staining for P40. So in small biopsies, we can only give a possibility of adenosquamous carcinoma. We cannot diagnose confidently as an adenosquamous carcinoma. So coming to pleomorphic carcinoma, it shows giant cells or spindled atypical large pleomorphic cells. This is one of our cases, which is showing these bizarre cells hypochromatic nuclei. So, usually associated with T253 mutations, IPDL1, and could have net exon 14 skipping mutations also. So, this is another case. This is a young female with hemithorax mass infiltrating the mediastinum and with multiple pleural nodules. So, the tumor here is showing very, you can see dark staining, and there are small cells, and at places it is showing some keratinization. And this keratinization is something that we call as abrupt keratinization. So this is P40 positive. Then we did another marker which came diffuse speckled nuclear positivity. So this was the nut. This is IHC for nut. So this was a nut carcinoma. So the nut carcinomas of mediastinum form around 50% of the totally described. So around 40% are described in head and neck, and rest 6% in the soft tissues. So these are characterized by BRD4 nut and fusions. And this is an extremely aggressive cancer with an advanced stage of presentation. So coming to another newly described entity, that is SMARCA4 deficient undifferentiated tumor. This is seen in young to middle-aged adults, and this tumor is also showing something called as a rhabdoid phenotype. So rhabdoid is basically, they are large cells with nuclear pushed to the side, and there are prominent nucleoli. So if there are rhabdoid cells, we usually suspect any kind of INI1 or BRG1 deficient tumors. So this is a case of BRG1 deficient tumor. It can also show other IHCs like CD34, SOX2, SAL4, synaptophysin. And cytokeratin itself is quite weak. So, and this is driven by biallelic inactivation of SMARCA4 gene. So, we can also see some salivary gland type tumors. So, commonly seen are adenoid cystic carcinomas, in which the tumor is seen in a cribriform pattern. So, and it is characterized by the MIB and FIB gene fusion. So, another entity is the mucoepidermoid carcinoma. So, this has mucin containing cells in addition to the squamoid cells. So this is characterized by the CRTC1 and MMN2 gene fusion. So it's important to differentiate this from an adenocarcinoma. So TTF1 is always negative in a mucoepidermoid carcinoma. So if there is lot of mucin in a core biopsy, TTF1 negative, we have to suspect a mucoepidermoid carcinoma. So coming to neuroendocrine tumors of the lung, so this is a precursor lesion. This is diffuse idiopathic pulmonary neuroendocrine cell hyperplasia. These are tumorlets less than 5 millimeters, and it could be sporadic or associated with the Dipneck syndrome. So this is a precursor lesion, and then there are well-differentiated neuroendocrine tumors and neuroendocrine carcinomas. So in the lung, the well-differentiated tumors are called carcinoid. So carcinoid can be typical and atypical. So typical and atypical are characterized based on the presence of mitosis and necrosis. So if less than 2 mitosis per 2 millimeter square and No necrosis, it is characterized as a typical carcinoid, more than 2 to 10 mitosis, and some necrosis characterized as atypical carcinoid. And it is also characterized by a very distinct organoid morphology. So organoid is basically the cells are arranged as nests or clusters, as you can see here. And these are very monotonous looking cells. And the nuclear chromatin is classically described as a salt and pepper chromatin. So if this morphology is there, we have to suspect a neuroendocrine tumor. So this is one of our cases. So these tumors are usually seen intrabronchially. You can see the bronchial head, the periphery, and this is the tumor. So it can also show spindling and effect pattern also. So this is the chromogranin IHC. So this is the granin protein located in the secretory vesicles of the neuron. So even this, the staining is cytoplasmic. So this is more of a specific marker, and chromogranin positivity is more seen in well differentiated than poorly differentiated tumors. So coming to neuroendocrine carcinomas, so small cell carcinoma, as the name suggests, it is composed of small cells. You can see the compactly arranged dark staining cells. So there is always crushing of the tumor cells, and what we call as nuclear molding, where a number of nuclei are seen as clusters. So these are these stain weakly for the low molecular weight cytokeratins and show positivity for neuroendocrine marker, and characterized by TP53 RB1 biallelic alterations. And if there is a non-small cell carcinoma in combination with a small cell carcinoma, that is called as a combined small cell carcinoma. So this is one of our cases. It is showing weak A1A3. A1A3 is a cytokeratin cocktail. So some epithelial differentiation. TTF1 is always positive in most of the cases, are positive for TTF1 irrespective of the site of the tumor. So this is another neuroendocrine specific marker, INSM1, that is insulinoma associated protein, and it is the most sensitive and specific. And synaptophysin is another marker of neuroendocrine differentiation present in the synaptic vesicles of the neuroendocrine and brain cells. Here you can see that this tumor, being poorly differentiated small cell, it is showing very weak expression for synaptophysin in the cytoplasm. Similarly, there is large cell neuroendocrine. As the name suggests, it shows a large cell morphology with a nested pattern. And there is mitosis, necrosis, and presence of neuroendocrine markers. So, coming to mesenchymal tumors, I will just touch upon this neuropulmonary blastoma, because other entities are very rare, and sometimes there are some chondromas and hematomas. But so this neuropulmonary blastoma is seen in young children and characterized by DICER1 mutation. So this is of type 1, type 2, type 3. Type 1 is present as multiple lung cysts. You can see dilated airways, and there are some islands of primitive looking cells near the bronchial lining. So once these primitive cells start proliferating and forming solid masses, so these differentiate into type 2 and type 3. So this is an image for type 2 and type 3 for these are small primitive looking cells. So just some points about lung dissections. So what all are important, what all parameters are important for reporting. So one is the location of the tumor, size, distance from the margin, presence of atelectasis if it is reaching the hilum, then histological type that we just discussed, and presence of visceral pleural invasion. So invasion of the outer layer of the pleura is important. In presence of satellite nodules, it's in the same lobe, ipsilateral or the contralateral lobe, that is important. Presence of metastatic nodules in the contralateral lobe. If there is post-therapy resection, presence of more than 10% viable tumor is recommended by the ISLC as a poor response factor, and spread to the lymph node and status of the margins. So these are some of the pathways of tumor spread. We can see tumor inside the vessel. This is a vascular invasion of the tumor. Then here we can see a nerve, and the tumor is invading this nerve. This tumor is invading the pleura. Then this is spread through alveolar spaces. The tumor cells are present inside the alveolar spaces beyond the margin of the tumor. This is also a poor prognostic factor. And this is the tumor in the lymph node. This was about the basic pathology. Thank you.
Thank you, Nupur ma'am. I'd like to invite Dr. Omshree to the next session.
Good morning, everyone. So after the basics of pathology, let's understand the next generation sequencing in clinical practice.
I will be. This is also. Yes.
So basic outline of my talk is with gene sequencing and its evolution, just to give you an idea. How many of you are very well acquainted with NGS, having been nowadays we're bombarded with gene reports. How many of you are aware of what is NGS, the basic principle? Just to understand. How many of you are aware? I'm not going to ask questions. No, so that's why they might not raise the hand. So just to understand, like, how much depth I need to go, or like how much I need to speak, that's all. So how many of you know what NGS is? So, okay. So, how the gene sequencing has evolved over a period of time? What is next generation sequencing? Its principle. The different sequencing chemistries that we talk about. Suppose whenever you are looking at the report, you should know that what kind of chemistry has gone behind in getting that data. And choosing NGS in the clinic, like what should be the right one? I know we keep hearing so much of information about exome and transcriptome and panel and CGP. So you should know, and its practical implications, and does it have any limitations.
Yes. Yes.
So, gene sequencing basically it's looking at the order in which those nucleotides are placed, and like basically it's adenine, guanine, cytosine, and thymine. And basically we are only looking at that. And advent of rapid DNA sequencing methods has accelerated the technology. And right now we are in a situation like it's just like a matter of 5 days you're getting it. It's like we're getting that instant noodles kind of a thing. Now we have instant sequencing data also needed. So why is it needed? So this sequences become indispensable. I mean, right now, just Dr. Nupur's talk, we said like so many different types of entities, like, this is fusion positive, this is TP53 mutated tumor. So how did we get to that? After looking into the gene sequencing data. So definitely this is needed for diagnostic, theranostic, prognostic, and also for forensic and various other implications. So DNA testing, how it has evolved, like it has first started from cytogenetics. So if you compare, cytogenetics is basically forest or the trees, like, you're looking into those big trees or a whole forest. karyotyping versus fish versus PCR and Sanger sequencing. So you're first looking into the whole chromosome, then you're looking into a certain region of the chromosome where you have those large structural rearrangements. Then you're just coming down further, like you're looking into now from the forest, you are walking into it, you're looking at those branches, that is what your PCR is. And then you're actually opening it out and looking into each of those cells, that's what sequencing is. So to put it in a very simplified form, from forest to individual leaves and trees is what sequencing is, just to give you an analogy. Or another, my favorite analogy is like karyotyping or any other conventional methods of looking into a disease or an alteration is, you're looking into the global, Google map, you're looking into a globe. And when you're doing sequencing, when you're looking into that one specific base, it's like you're going to the Google map, coming to this exact location, like, India, Mumbai, TMH, this room. So that is what sequencing is all about. So this is how the technologies can be. So next generation sequencing, basically it's the best of both worlds. It looks into the structural rearrangements also. It's looking into the fusions, and it is also looking into those single base pairs alterations also. So large scale view with a very high resolution. So history of gene sequencing, again, it started with Frederick Sanger introducing the Sanger sequencing, where we are looking into those individual or the sequence of those nucleotides, which was in 1977, moved to 2005, where we got into the second generation sequencing. And then today, in an era, we are talking about NGS on a chip. I mean, you can actually do next generation sequencing on a pen drive size system. You can attach it to your laptop and you can carry it home from there. As per Moore's law, as the technology is becoming more and more advanced, the cost of sequencing has gone down and down. So because of that, we are able to see so many labs mushrooming up, so many reports of NGS, and so many data coming up, and which is definitely helping us to understand the disease better. So what is, absolutely, we looked into the high resolution, broad view, and targeted, that is whole exome, clinical exome, and then panel. So this is where we have to pay more attention. So whole exome sequencing is you're looking into only those coding regions, that is exome. We're not looking into the whole genome. And clinical exome is again where which is clinically relevant, where targeted therapies or any prognostication or implications are available or risk prediction can be done. Then we come down to panels. Now, these panels are most easily manageable because depending upon the type of sample, whether you have very limited tissue, whether it is a very limited amount of cells, these panels give you a much broader, a very deeper understanding of what you're looking for. I mean, for the drug, what you have, whether there is any biomarker available. So these panels can vary from few genes. It can be from 3 to 5 to 10 genes to up to 500 to 1,000 genes. Again, these are all clinically relevant genes for which actionable targets are available. So this makes large-scale sequencing possible, less expensive, more sensitive for low-level variants, and can detect even novel new variants. So compared to NGS versus Sanger, I mean, nowadays we don't even hear much about Sanger sequencing, but Sanger sequencing, let me tell you, till date is the gold standard if you are looking into something novel. If you are discovered something on NGS and if you want to confirm it, still it is Sanger. But the disadvantage is that the Sanger is looking at only one gene at a time, whereas in NGS, you're looking into millions and millions of reads or genes at one go. So the technology is, of course, evolved using Sanger as a basis. So NGS is very quantitative. This is not quantitative. NGS is definitely complex. This is less complex. NGS is faster. It's more cost effective compared to Sanger. So this is again explaining how exactly the working of, so here conventional days, like what we are still doing it. It's not that we have given a unit Sanger. You are basically looking into one single target of a gene, and then you're sequencing base by base. And this is where you're looking into this 1 point mutation. Whereas on NGS, what you're doing this millions of reads. All these what you can see on a flow cell, these are the data points. So these data points are then finally translated into these signals for individual bases. So like this, there are clusters of these information available. So from one gene, you're looking into million genes. So that's the resolution and the data. So what are the basic steps of NGS? I mean, we keep saying that, the report nahi aaya, time lag raha hai, we are into processing. So that's because we do all these things. So it's not that I'm trying to cover up for the delay in the report, but I'm just telling you what goes into NGS testing. So right from specimen collection to nucleic acid isolation, library generation, sequencing, data analysis. Sounds so simple, isn't it? So it isn't. I mean, I'm just telling you these are the basic steps. So now when we are talking about the different platforms, different chemistries, they vary in terms of these library generation and the sequencing chemistries that they use. So there are major players in the market like Thermo Fisher Scientific, there is Illumina. So, you know, there is, you must have heard about hybrid capture panels, or you must have heard about amplicon based chemistries. So they all differ the way you are making your library, how you are making it, how you are generating your clusters, and finally how you are analyzing your data. So simple, I'm talking about a hybrid capture. So what you're doing is nothing, you have a sample from where you're extracting your nucleic acid. What you're doing, you're making into like chopping it, you're making into smaller fragments, because here we are looking into small fragments, and then we are assembling it all together. So we are taking this sample, we are extracting the DNA or RNA, and then we are fragmenting it. So this fragmentation can be done using any of these. We can use sonication, we can use acoustic waves, or we can even use enzymatic fragmentation. So once you know that what is the size, so usually we talk about, you know, what is the size of a library, whether it is 150 base pair, whether it is 200 or 300. So why is it needed? Because you need to make those fragments, and then accordingly you can attach your adapters and you can sequence it. So you do that, and then once you do the fragmentation, there is something called as end repair, because these are like just randomly chopped. So you will have fragments of different lengths. So you want a specific length. You don't want any poly tape hanging over there. So you will do the end repair, and you will add these synthetic adapters. Now, why these adapters are important? I do not know what is lying over here. I don't know the sequence of this, but I know what sequence is this and this. So this is going to help me in sequencing. So I have to attach adapters to all my fragmented nucleic acids. So these adapters are attached, and this is how I'm making my library. So then what I need to do once I've added my adapters to my nucleic acids, now I need to know, because those are really very, I mean, hardly we start with something like 50 nanograms or 100 nanograms. With that, it is extremely difficult to figure out what you're looking for. So I need to amplify that. So I need to make a clonal amplification. First, what I did, I made a library, and then I did the clonal amplification. Now, this is emulsion bead based PCR. This is what Thermo Fisher Scientific basically uses. And this is the surface flow cell base. This is what Illumina uses, whether it is MySeq, NextSeq, MOSSeq. They all make use of this technology. And whether it is Iron Torrent, S5 Genexus, they make use of these emulsion-based PCR. The concept remains the same. You are just amplifying it more number of fragments, but what methodology? So this is oil in immersion beads. So inside this, what you have is that your adapters are attached to these beads, and on this your nucleic acid is present. And using this adapter as a known region of your sequence, it's like your primer, and you add your complementary primer. Your synthesis of complementary sequence goes on. Your sequencing begins. Whereas on a chip over here, what happens is your adapters are there. You bind the fragments what we saw in the previous slide. That comes and attached to this, and then it starts sequencing. Okay. So once that is done, so again, as I said, it is Thermo Fisher, Illumina, and Nupur is it's like a third generation sequencer. When we are looking into one nucleotide, it doesn't require library preparation. So the pH-based sequencing Iron Torrent, let's not get into the details of the chemistry. I'm just stay with me. I'll explain it to you at a simplified manner. So this is basically a sensor based. So what is happening is that as and when the nucleotide is being added, so the pH the hydrogen ions are released, and these are captured, and these are your data points for A, D, G, C. So there is no fluorescent signals. It is the hydrogen ion which is released that causes the shift in the pH, and that is being captured by the system. So you are reading that data. So it is the pH-based sequencing in Iron Torrent. Whereas this is called as a sequencing-based synthesis. So the previous one was amplicon-based library preparation, and it's a pH-based sensor which detects the shift in the pH as and when the bases are added. Whereas here it is the fluorophore, because each and every nucleotide, whether A, T, G, C, all four of them have been labeled with a fluorescent dye. Okay, so and as and when it gets attached, these are being captured over here. So then again, it is a two-dye chemistry, so that there are different complexities. So once you do all that, it is loaded onto the flow cell. So this is the flow cell which goes into the next generation sequencing platform and onto which the sequencing reaction happens. Okay, so we are done with the library wet lab work. So that was the wet lab where you were like getting your nucleic acid, fragmenting it, creating a library, sequencing it. So you have done all that. So now you are coming to the bioinformatics or the pipeline. So what we are doing, we are looking to the primary analysis. So this is done on the system. So what we are doing, raw sequencing data to the high quality sequence reads. You must have seen those are all in the forms of those pictorial presentation, like those dots, right? So those dots need to be translated into what bases they are, which belongs to A, which belongs to B. So like huge number of data that is just piled up. So system is just converting those data into the reads. Okay, now I'm talking about reads. Earlier it was data. What are reads? Reads are your nucleotides. Okay. So it is just converting into high quality sequencing reads. Now again, this quality of sequencing read will also depend upon your DNA that you have put. How good was your fragment? Sometimes if the tissue is too necrotic, if the DNA is too degraded, you will not get good quality reads. So then it becomes extremely difficult for you to analyze that data. So once this is done, sequencing reads are done, the secondary analysis. Now what is the secondary analysis? It is aligning sequence reads to a reference genome and identify variants. So it's basically what I can give an analogy is like, it's like you need to have a book of say 1,000 pages with specific indexes and chapters, correct? So you don't know, the pages are like thrown all over the place. It's just thrown all over the place. But they have those numbers. What you're doing is, you're just going and picking up all the pages together from 1 to 1,000. You're just compiling it together, right? And then you're making it into a book. So this is what is happening with the sequencing reads. It's all thrown all over the place. But you need some reference format. For that, you're using the reference gene sequence. You're aligning your reads to that, so which belongs to chromosome 6, which belongs to chromosome 7. So all those reads are aligned to the reference gene. And then once everything is aligned, you know, okay, where are your sequences aligned properly and how good they are. And then you do the tertiary analysis. What is tertiary analysis? Now, this is where we do the filtering. We are removing all the redundant data. We are looking into what is relevant to us, like, synonymous alteration. We will remove the SNPs. We're only looking into those pathogenic alteration, any nucleotide variants or any deletions or any duplications, So, and then finally going to the clinical report. So first is what you're converting your FASTQ to BAM file, variant calling files, and then it's your clinical report. So FASTQ file sequence reads are taken out from the data points, and then each of those bases are assigned a quality value. So based on that, you must have heard about, you will see in the report, we talk about Q30 is more than 90% or Q30 is less than 90%. So what is Q30? It talks about the error in adding the sequence, like 1 in 1,000 reads, if one base is added erroneously. So that is your Q30. So if it is, it should be more than 90%. If somewhere a report has where Q30 is 50%, then you would have doubts, because it's a spurious data. So all those quality scores are added to this, and then you will fall all those bases, like what is AT, GC and all that, and demultiplexing. Now this is where you're sorting all your pages which are numbered. So that is demultiplexing. And that data is in the form of FASTQ files. You must have heard this term, FASTQ files, after sequencing is done. And then, so this is how the data looks like. This is all the NGS data which is built into FASTA, which will be in 2 lines, and FASTQ in these 4 lines. And then comes the secondary analysis, aligning sequence reads to a ref genome. So this is GRCH37, HG19 or GRCH38. So based on these, you will align your data. So this is like the reference genome, which universally all the sequencing data is referred to this. So this is the standard. So this is what it is, and you will compare your sequencing reads to this. So FASTQ alignment, now you have a binary alignment map. So once you get this binary alignment map, you get these variant calling files. Okay. So this was your secondary analysis. So from FASTQ, you move down to BAM and BCF, correct? From your data points to sequencing reads. From sequencing reads, you are aligning it to your ref genome. From there, you are calling the variants, correct? And then your tertiary analysis. Now you will actually look into, now the interface is in front of you. This is where we all look into the data. Once all this is being done by the bioinformatics pipeline. Okay, like what is an indel, what is the CNV, what is the single nucleotide polymorphism, and how do we filter it? By subjecting it to various annotation databases. Like, you have 1,000 genome, you have TCGA, you have OncoKB, there are various things. And then we subject it to tiering. You must have heard about tier 1, tier 2, tier 3, tier C, tier 4, and then A, B, C. Okay. So once we do that, and then you finally give the clinical report. So how does it work? The wet lab, DNA, fragmentation, ligation, then you do sequencing, either pH based or it is sequencing by synthesis. Then your reads are taken out, that is FASTQ files. These are aligned BAM files. You do the variant calling files. Once this is done, then you go for the tertiary analysis. Tertiary analysis where we all sit and work once the data is out. Okay, so and then library preparation talks. So what are these? Just to get you acquainted whenever you are looking into the reports. Enrichment. So that is what kind of method was done to enrich your DNA library. Amplicon-based target enrichment, which I mentioned that we're using PCR to do it. And hybrid capture, that is that we're using oligonucleotide weight. You saw those flow cells and the chip on which the bases are added. And exome sequencing, that include all exons, whole exome sequencing, exons of all genes, clinical exome sequencing. Okay. So Q30 or the Fred score, percentage of bases sequence with a quality score of Q30. I mean, only 1 in 1,000 bases are added erroneously. So Q40 is even better. So reads a sequence of a base pair determined for a given DNA fragment. Depth of coverage. Again, this is extremely important. Like how many times a target region has been read by the sequencing system. So suppose if you have a gene, say for example, you're looking into EGFR. So that is there in your targets. And if the sequencer has read both forward and reverse more than 500 times, so you will have more confidence, okay? Or whether it has been read almost 1,000 times. So that means you will have more confidence in calling the particular mutation that yes, this region has been sequenced at least 500 times. So whatever mutation is there, it is more relevant. So that depth of coverage. So as per the international consensus or the AMP guidelines, they say 500x is the recommended. So any report, if you see, always look for depth of coverage, whether it is more than 500x or they usually write. Okay. Then the FASTQ files. Now these are the sequencing reads with the quality scores. BAM files, these are the reads which are aligned to your reference genome. VCF are the variants which are found in the sample. So VCF files. So always you must have heard people talking about. So now you know what exactly this means. And then value of NGS in general, it's very cost effective considering the amount of data. And we all have been seeing how we have moved from sequential testing to directly NGS, how it saves time. Earlier it used to be IHC and then EGFR and then ALK and then ROS and then, so you're cutting your section so many times. Now it's just one section and you're extracting a nucleic acid and you have all these information at your disposal. So it's one assay. And tissue stewardship, small biopsies, often not enough tissue for multiple molecular testing. So this is exactly what I was saying. We are prioritizing the tissue for accurate diagnosis and always deciding on whether cost is more effective, whether this test is more clinically relevant, how much use it is going to be in the clinic for the patient, whether it is really needed. So all that the laboratory needs to take a call. And then there is something called as how do you choose a particular biomarker for an assay. So there are AMP-based guidelines also. And there is something called as ESMO scale for clinical actionability of molecular target or the SCAT. So what does it say? It makes you ask these questions. You can go and look for this paper. Should NGS be used in daily practice? If so, should large panels or genes be used? So there is again SCAT level, again like tier 1, 2, 3, 4 classification of AMP and ACMG guidelines. Even SCAT takes the same thing. So what does level 1 to 4 ranks match between drug and the genomic alterations? So level 1 means which is validated in clinical trials for that specific disease. Okay. Level 2, whether that alteration is being there in randomized clinical trials. Level 3, I mean the same alteration is there, but it is in some other cancer, not in the disease what you're looking for. So consider level 3. Level 4 is hypothetically targetable alteration, preclinical data, or maybe it's an in silico analysis. We do not have much of in use or the routine data on that. So it is level 4 or it is equivalent to VUS or variant of unknown significance. So based on this, you can prioritize. So guideline recommendations for predictive biomarkers are emerging biomarkers. So we know what are the predictive biomarkers and what are the emerging biomarkers in lung cancer. And then you must choose wisely. And what are the barriers for universal biomarker testing? Basically, communication is a key. And this is This was a survey which was conducted by the oncologists, like what would they prefer, whether they prefer large panels, DNA, RNA. So this is done by Illumina just to understand what is the level of understanding among the clinicians and what exactly they want. So 37% of the clinicians are for large panels, which is inclusive of DNA, RNA, and how many of them are for small panels, and how many of them are actually preferring whole exome and whole genome sequencing. And what was their prime concern regarding understanding the reports among the clinicians is like basically they really don't know what to do with variant of unknown significance. Cost is another factor, and the result accuracy, how to interpret the result, what to do with those incidental findings, what should they take a call, and the turnaround time. And challenges and possible solutions, as communication is the key, always having multidisciplinary tumor board meetings to discuss these findings is extremely important. And how are we doing with the recommended testing? So limited data is available, especially beyond testing for EGFR and ALK. So I guess this is the 2018 data. Now the scenario would be definitely changed. So a value of NGS, to summarize it in technical terms, simultaneous testing of many genes. Some assays and bioinformatics pipelines can detect many different type of variants, and excellent analytical sensitivity, detection of low-level variants, and even germline mosaicism, somatic tumor testing, low-percent tumor cells, multiple clonal populations. Limitations, the initial setup is quite expensive, the reagents are quite expensive, the way you get those reagents sometimes might not be that conducive. So, and small batches are not effective. Sometimes when you're sending liquid biopsy, if it is only one sample, because you need to run a very high depth of coverage, so running just one blood sample might not be cost effective. Kumar sir is smiling. So we need more and more samples so that you can run everything at one batch, so it becomes cost effective. And bioinformatics skill set. Right now, of course, there are different commercially available pipelines are there. So we are not getting into the nitty-gritty of developing our own in-house bioinformatics setup. So these like Sophia, DDM is there, and then Period is there, and then even Indian Dragon. There are many of these others. So they make our life much more simple and easier. But getting these, they all come up with a specific cost. So that is an initial issue when you're setting up a lab. And technical is, of course, every assay is platform and assay dependent. And sometimes large alterations can be missed. Of course, nowadays, more and more companies are coming up with more and more inclusive kits where they are including larger divisions, but still larger structural chromosomal aberrations can be missed out. And sometimes when you have too many samples with the copy number variations, the bioinformatic pipeline may miss those. So that is because, I mean, they always say that they a sensitivity in picking of CNVs. So suppose in a batch you have say 10 to 15 cases all with an amplification, you may miss some of those cases. So those are the caveats. And yeah, so that's all. And thank you.
One time, maybe the questions or queries from students. Very nice lecture by you. Anyone? मॉलिक्यूलर टिमर बोर्ड अटेंड करा है? किसने अटेंड किया? कभी भी? रिपोर्ट ही नहीं देना है इनको। ये जो फोन आया ना कि वो एनजीएस की रिपोर्ट की तरह है, इनको बोलना है ऐसा करो जी, जब तक मॉलिक्यूलर टिमर बोर्ड में दिखोगे नहीं ये रिपोर्ट नहीं मिलेगी। तो is it link? Do you know the link? There's a link to molecular tumor board. It's online. Everyone knows. सर हम तो सब पता ताजमहल गए थे, सर जाते नहीं वहाँ पे हम लोग। तो नेक्स्ट टाइम ओमश्री आने वाले भी क्लास लेने के लिए अगर ऐसे if you behave this way. Any questions regarding NGS or histopathology? So if none, yes, go ahead.
They write the tumor adequacy. So what minimum number of percentage we needed
Tumor adequacy.
and
Adequacy किस चीज की थी?
then
Molecule.
the
Tumor adequacy, then will what she writes and what she accepts. What do you think is adequate?
basically 20% cutoff is recommended for NGS. PCR we can go to 10%. So we look at all the tumor cells in a sample and divide it by all the other like the stromal cells, immune cells. So we calculate a percentage of tumor cells. Then B for MGS,
Let me
we
see.
still push page 10.
Yeah, correct. I wanted to what after getting 20, how much we can convince it. So what is that minimum?
20 is comfortable if you are getting good deal of really an argument. 20 is not just the way for 10 months, and then we will do and the chances are that we might miss some points of corrections.
Like, put it this way, if you're doing at 10, if you get positive result, be very happy. If it's negative, you know there's a chance of missing. It's a fair message. So at 10, when you're doing, it is not useless. Remember, you may be getting false negative. There's nothing called false positive in less than 10%. अगर positive आया तो बहुत अच्छा है, खुश हो. Negative आया, then you know there is a problem. There is a potential to miss it. Clinical relevance क्या है? If you have adenocarcinoma, they are non-smoker. Then you know these are patients where the chance of being something positive is around 70%. And in that case, we say if you got negative, you need to think क्या करे, biopsy करे, blood में करे. You need to have some safety valve for it. But safety valve is not good enough. You want that 20%. If not, then these are some alternatives. Any other question by anyone? Go ahead.
So the liquid NGS, how much blood will transfer? For example, EGFR.
0.2%.
Perhaps in liquid biopsy, what we should consider relevant. So what Dr. Omshree suggested, 0.1% होता है, be happy. मैंने जब start हुआ था तो 1% बोलते थे, अब 0.1 plus कि उसके नीचे में जा सकते हैं क्या? But I 0.1, remember 0.1%. After that, have dialogue. Many lab they less than 1.1% they report it, and they will mention it is less than 0.1%. But then have a dialogue with your lab person. इसका करें क्या?
0.1% for a pathogenic population.
Pathogenic. But we put other 0.09 आया, and you may not report, but there are labs which report, and they reported that they mention it. This is the bad. And say have a dialogue. Idea is that you know it. Escape beyond. Escape. Be careful about intervening. Aditya, last question.
The data generated from Capricorn or Illumina, can they be interchangeably interpreted?
Interpretation can be done once you have the VCF files, whether it is done on it's only the chemistry that is used. So usually in the amplicon based chemistry, you're doing the PCR. So in that what happens if there is some erroneous basis happening, the chances of that error can be multiplied by much. So that is the only challenge. Rather than hybrid capture, that error is minimal. But data, once you get the VCF files, you can do analysis.
Ultimately, what madam see, ultimately ACTG है. So जब आपके पास जो आता है, finally जब मैंने आपके पास में जो bioinformatics what madam finally sees and analyze, it is ACTG and then you analyze this. Last support. अगर जल्दी पूछना है 2 सेकंड में पूछो then we can have it.
There are so many labs and so many NGS, like everyone is doing NGS. We have to decide the NGS. So we look at depth of coverage and clinical trials that we should be looking at.
The panel, of course, and it need to be inclusive. You're not looking at the 5 of NG panel and the papers and population solutions. But whether it is an application laboratory and then depth of coverage, of course, the future values and the comprehensive message. The confidence.
The question which will come useful for you and useful in your practice also. If you can have one thing, but there are many things you suggested. If tissue कितना होना चाहिए, 20% हो, उसमें DNA कितना extraction किया, उसकी quality कैसे? In your one page 10 things, so they know कि जो report आती है, they can that will be reference for these things you can check in the report is there or not to say it's good quality report. So madam mentioned some of them. Madam checks all of them which I suggested. From the how much is the tumor, DNA extraction was कितना हुआ, वो quality उसकी कैसी है कि नहीं, and then it goes with it. Correct? Anyone has questions? Yes.
How do we compare between the quality? Is there a final assessment? There are some broad points which we will see, but on different platforms which we access with an extension of what we asked. How do we compare with these are better quality driven apps or better, more organic reports? Some final points you want.
Big question, but mostly it's the accredited laboratory and the depth of coverage and the variant frequency and what are the annotation softwares, what they're using, what pipeline and what platform. I mean, I think we need to see the report to see. I mean, like if you have a foundation report, if you have a genome report, if you have KMH report, so you will, and then most of the times we do have concurrence in the data in the foundation. So it's a, I think with practice we develop that.
Dr. Omshree saying that you need to see lot of things. And as the time goes by, you use the lab, you get the hang of those things. Where you're going to get. So I don't remember labs having 4 or 5 mutations in one, all of them driver, and they insisting upon this is a good report. Then you say, you know, this is with this lab and so that people and madam makes very useful. I think so. I've heard you earlier that you make see those 10 things and keep checking it. Well, hurry report money hota, but if you ask the lab, they will provide you those 10 things, and then you can say, okay, what I finally got. So that's my last question. Question.
So enteric type adenocarcinoma with a big lung mass and UGI and colonoscopy negative, NGS negative. How do we treat?
Madam, how do you treat? Enteric adenocarcinoma, NGS negative, lung, colon में कुछ नहीं है, but lung mass है. But enteric adenocarcinoma is known. It's a known entity. It is called enteric. You do have an intestinal variety of adenocarcinoma in maxilla also. But we don't give fall pops. People have given fall pops, as but we treat them not exactly like a colon cancer. Anyone? Any last question?
So sometimes you get specimens that are very old. So how far back can we go for before we can perform an NGS? The old specimens, like 6 months, 1 year.
6 months, 1 year definitely works. I mean, like,
5 साल पहले, 1000 साल पहले, बड़े सारे रिवर ये हो रहे, ड्राई हो रहे, वहां से बड़े सारे चीज निकल रहे हैं जगह पर दुनिया में.
After 5 years, you can tell, but initially we do the QC checks. I mean, not only the tumor is adequate on the FFP section, but we extract the DNA and then we do the initial QC. And then that QC, if it doesn't pass, then we will not take it. So whether it is 2-year-old, 3-year-old, 5-year-old, we will still try. If it is a good amplifiable DNA and RNA that is present, we will do on it. Otherwise, we will not do it.
I think there's no need to this. It was only one randomized trial ever done in screening in oral cavity cancer. That was done in Kerala. Shankar Narayan saw that. It was a negative study, so-called positive. Someone has a tissue of that lady, I think she would have met you, but she has definitely met pathologists. I'm aware of that. That lady has a tissue. And it's such a precious tissue. And this is the same thing that it continues. But this trial was done maybe 20 years back, 25 years back. I think I remember. Definitely 20 years back because I was doing that time. And that lady has, Dr. Kumar, these are tissues. लेकिन हम सिर्फ करें क्या उनको जैसे वो टच करो जो आप बोल रहे हो एट व्हाट मैडम इज सेइंग सो आइडिया इज व्हाट इज द मैसेज देन मैसेज इज first preserve well, which we don't treat our tissues so well. We need to start living with structures. We should treat our tissues well. Second, preserve things like you preserve DNA. That madam can give you DNA after 20 years. Absolutely, it will be as good. Tissue is a problem. So if you want to do something, so message is that you want to get into research, you want to do something, tissues of 10 years old, 20 years old, and that time when you get tissues, take out things where you can preserve and preserve well, and on that you can work 20 years, 30 years down the line. And that is what then I realized this is what, and this is the only randomized trial ever done in oral cavity cancer. And that person has a tissue, only this not preserved well. Otherwise, this would have been remarkable work. And that person has a fund, except that person is roaming around everywhere. How to get the DNA and RNA from it. So, I think so. Any last comment by anyone? Madam, any last comment?
What the benefits of RNA?
So RNA panels are basically for fusions you are looking into it, that, I mean, usually most of the assays nowadays are combination panels, but still things are evolving, even fusions are being looked at in the DNA panel. It's all about saving issues and getting more information. So a DNA panel using convert the DNA panel you will convert, I mean, RNA you will convert the RNA into cDNA, and the panel is designed for RNA specifically looking at those alterations, particularly even for RS fusions or BR. So mostly fusions, and DNA will be mostly looking into your single nucleotide variants, insulin deletion. But nowadays things have changed to an extent. There is something called as RNA oncology solutions, where you just need to get the RNA, you convert it into cDNA, so you can look for conmutations, deletions, fusions, CNV also in that. And also at the same time, you also have other panels where from the DNA only you can look into fusions, CNV, everything. So it's depending upon how you have validated and standardized and how cost effective you can make it. But predominantly the dictum is RNA-based assays are mostly for fusions.
So at times, Omshree, we also want from the labs that tissue was not so adequate and you could only extract RNAs.
Mostly it happens with DNA. RNA is mostly unstable, so RNA is most of the time is uninterpretable. Because RNA quality is even more degraded, so you're not able to get good cDNA on the simplify RNA. That is it.
So we should
It's never the other way around. Mostly it is DNA is much sturdier as compared to RNA.
So in all such cases, you suggest that we should ask for a repeat biopsy and
If possible, please. Because even in liquid biopsy, you're only looking at the ctDNA, and there also you do not detect fusions because you need an RNA test. But now with these new advanced kits and you can do it.
And what is your one word of opinion about the very targeted focused panel which was, because they are much cost effective and many labs are offering. So we are also offering that.
So it is really good.
So given a choice, if patient is not doing affordable portion, then or vice versa.
I mean, it's a debatable question. I mean, if money is not an issue, then we will definitely go for comprehensive genomic profiling, because at one go you're getting a whole lot of information. But if infrastructure where it is not developed and we do not have that kind of an access, then targeted panel is more best.
Last question, so are liquid biopsy are you doing fusion?
Yes,
So that
yes,
that we are.
yes.
So it's not, I think so 9:40, it will be the service file. Thank you so much. It was such a nice. Thank you.